Welcome back to another video on the Student Physical Therapist. My name is Jim Hefner. I'm the owner of Hefner Health Physical Therapy, which is located in Boulder, Colorado. In this video, I promise to offer you some differential diagnosis of lateral knee pain. And we're going to cover that from the soft tissue causes of lateral knee pain, the skeletal pathology that can be involved, the nerve pathology, and then sort of the other category. And those combined is sort of your total slew of the things that can happen for the lateral knee. Now, the thing I want you to think about first and foremost is that the knee is somewhat similar to the elbow. And what I mean by that is that the knee above and below has to deal with the ankle and the hip. The elbow has to deal with the shoulder and the wrist. So with the knee joint, our hip and our ankle have tons of rotation built into them. And what that means is we get rotation, or we can generate rotational torque from the joints above and below the knee. And that means the knee primarily does flexion and extension. Some people hate to hear it, but the knee is primarily a hinge joint. Now, we do have some involuntary built-in tibial internal and external rotation. So as I kick my knee out straight, there's some involuntary tibial external rotation. And then as I bend my knee, there's involuntary tibial internal rotation. And that can best be seen when someone does a squat, the knees need to internally rotate, and that internal rotation as you go into knee flexion allows you to load weight through the medial arch of the foot, and it allows you to generate a lot more rotational power. So the knee is primarily this joint that's stuck in between these big rotational centers of our ankle and our hip. Because of that, a lot of the pathology that we see at the knee is due to things that are not happening above and below. So you'll see that, yes, we're going to cover all these diagnoses, but the magic is sort of at what's happening around the knee. So if you guys would do a quick test of stand up and first do a squat and really sit the weight back into your heels, sit your hips back as far as you can, and then retest the squat. And this time go onto your toes as you squat, where you squat straight down and not back. And what you'll feel with those is that how you move really dictates where the stress goes through your body. As I squat back into my heels and sit my hips back, I load the glutes and the hamstrings, and the force primarily goes through my hips and my pelvis. Now, if I squat onto my toes, that is going to load the anterior chain, being the quadriceps, a lot more. And however you pattern that strategy is going to be where the stress goes through the body. So if you're always using your quad, like if you're always doing a quad dominant squat, which might not even be a popular term, then there's going to be a lack of symmetry or balance between how you squat one way versus your ability to squat in other patterns. And what I always look for is the ability to achieve both of them. So I want to be able to do sort of a knee driving way over the toes, but I also want to be able to pick up really heavy things, which is going to be more of a glute hip activation. So we need to be able to do both of them. But the more important message for your clients too is how you do those things just determines where stress goes through the body. So if you're someone who really utilizes the quad driven pattern, emphasizing the other pattern can be a great way to temporarily offload the knees as you get that person stronger. There's no there's no best or right way to move. There are certain situational ways to move that can help you with certain activities. If you're going to be lifting really heavy things, I highly recommend looking at how Olympic lifters and power lifters achieve those things. If you have a job that requires you to get low to the ground and get underneath things, then likely being able to use your quads for those as a strategy that way is going to be very important. It's all situational. So with lateral knee pain differential diagnosis, we're going to actually start with the things that are not with the knee joint first, and that's going to be our other pathologies. And the way to determine that the knee is not the source of symptoms is that you do your localized knee exam, and it's going to be fairly negative. So if someone comes in and they have lateral knee pain, as I'm moving their knee, I can't reproduce it with extension overpressure. I can't reproduce it with flexion overpressure. My tibial rotational testing and ligament testing is negative. All of a sudden, I'm wondering, what are the things that are above or below that can be contributing to those symptoms? And The two biggest ones are going to be the hip osteoarthritis. So if someone has a lot of arthritic changes in their hip, there can be a referred pain down to a referred or just a mechanical change that occurs down at the knee to offload the hip joint. That same person with hip arthritis is likely going to be an older individual. They're going to have greater pain in the AM. Their hip is not going to move well into flexion and internal rotation. Those are all signs that they have some hip osteoarthritis or a hip related condition. The other thing can be a lumbar radiculopathy. And we're going to swing this one right over to perineal nerve injury afterwards. Because if you look at the dermatomal and myotomal patterns for the lumbar spine, L4, L5, even S1, those track right across the lateral knee. So if someone's having some lumbar radiculopathy symptoms, we might be seeing some pain sensory overload at the knee joint as just simply because of how the nerve referral pattern works. Again, that person's going to have a fairly negative knee exam. When you have them in supine and you're taking them through flexion and extension, when you're checking their range of motion, it's not going to be very significant because symptoms are coming from somewhere higher up. Now, let's say lumbar radiculopathy is the lumbar nerve root. So as it exits the spine, the nerve root is getting aggravated. Now, let's say that's okay. Then we could be some other nerve pathology that's happening lower down. And if you remember back to anatomy, the sciatic nerve, as it gets, into that popliteal space behind the knee, it turns into the common perineal nerve and the tibial nerve. The tibial nerve runs medially or kind of posterior medially down into the foot. The common perineal nerve wraps around the fibular head, so the lateral aspect of the knee, and that's where it branches into the deep and superficial perineal nerves. Now, if there is some injury or aggravation to the common perineal nerve, we're going to see some sensory issues or sensory and or potential motor changes to what's happening at the foot and ankle, but that could manifest as some sort of knee pain. Oftentimes, it's not going to be even as much pain on the lateral side of the knee. It's going to be more of these motor changes or sensory motor changes that we see down into the foot and ankle. But because of the location of the nerve, especially if the nerve's getting aggravated more in that common perineal nerve attachment, that's where we could see some sensory overload into the lateral aspect of the knee. So those are our three other pathology and nerve related things that can relate to knee pain. The bulk of where physical therapists and musculoskeletal experts spend their time is going to be in the skeletal pathology and soft tissue pathology. So let's get into those next. I want to start with skeletal pathology, and we're going to bounce similar to my video on shoulder anatomy and biomechanics. We're going to bounce back and forth from the lateral knee pain mind map and then go into the essential anatomy app, which is such an amazing app for looking at the layers of tissue. So on skeletal pathology, the four main things that can cause lateral knee pain is going to be a fibular head fracture, osteoarthritis of the knee, patellofemoral pain syndrome, and then patellar subluxation or dislocation. What I want you to think about with these is that if it's a patellar subluxation or dislocation, or if it's a fibular head fracture, there's likely going to be some immediate trauma associated with it. So at the bottom here, I put our diagnostic approach for lateral knee pain is we need to take a thorough history and exam. We can refer for imaging, and then we need to rely on our clinical special testing to help determine the cause of one's knee pain. And with these two, as you're doing your physical exam or the history of what's happening, they report some sort of trauma. Then we can think about either it's going to be a patellar subluxation, if it's not soft tissue related, on the skeletal side, a patellar dislocation, or potentially a fibular head fracture. So we're going to switch gears and go over to the Essential Anatomy app. I'm going to peel back the soft tissue. And you can see that if it's a patellar dislocation, usually that happens with a lateral patellar dislocation. I'm actually going to add this back on. The patella is well positioned in the middle of the knee with all this surrounding soft tissue, all this connective tissue. If you take a blunt force trauma to the inside of the knee, it shoves the patella laterally and it can strain some of the ligaments, the things that hold the patella in the groove there. Ideally, it subluxes or dislocates, and then it pushes right back into its position. There can still be some ligamentous strain that's associated with it, but it's that immediate direct trauma that then causes inflammation, it causes pain, it causes some instability that can occur around the knee. Next one that we had is the fibular head fracture. So if you look at the fibular head here, there's tons of stability. We have ligaments, posterior ligament of the fibular head. We have an anterior ligament of the fibular head right here. It is fairly stable in that position because of all the soft tissue connections around there. But if there's a trauma to the lateral side of the knee, we might see a fibular head fracture or a fracture of the fibula somewhere. But if it's at the fibular head, that's going to be the indication for some lateral knee pain. The other thing then is going to be osteoarthritis of the knee. With osteoarthritis, there could be some prior trauma when they were younger, but the biggest thing with osteoarthritis is going to be a degenerative change of the knee. So um, we're gonna get into the meniscus in a little bit, but if you look at this is the articular surfaces of the tibial condyle. So both medial and lateral. For lateral knee pain, we can, for this purpose of this video, say that they're going to have too much lateral loading or lateral compression on the knee. And that is it can be due to wear and tear. This is the articular surface. Right above that is where the menisci sit, which are not shown in the picture here. We'll show that when we talk about a lateral meniscus tear in a little bit. But there's going to be some wear and tear, a gradual wearing of the lateral meniscus, which then brings that bone-to-bone contact closer. So instead of there being a pad of shock absorption between the femoral condyle and the tibial condyle, this increased loading bone to bone is going to create increased degenerative changes in the knee. As the soft tissue cartilage wears down, the bone starts rubbing and creating friction on itself. And that's where we see osteophyte formation. That's where we see increased bone growth and things associated with knee osteoarthritis. The more progressed or the more crepitus, the more of that creakiness in the knee, for me, is typically a sign when someone needs to go see an orthopedic surgeon. And that can be controversial. We always want to take a conservative approach, see if we can change around their movement strategies, their loading strategies. But if those aren't working and they're still having significant amounts of pain and disability, that's where we need to start talking about other potential surgical things. But always, I mean, I'm always giving the conservative approach, a very strong conservative effort for several months. But what's nice is if they do need to go into surgery, we're going to have built up their strength. We're going to have built up some of their movement patterns to better help them if they do end up having surgery. The last one, I'm going to add on some connective tissue here. And then the last one on the skeletal side, which I put, is patellofemoral pain syndrome. And that really is due to the soft tissue that pulls through the patella. But I put it under the skeletal side because it's the kneecap tracking, abnormal patellar tracking, that is sort of causing that problem, or a sensitivity around that. So as I'm adding the layers of muscular tissue on, if there's too much, let's say if there's limited hip mobility or too much tightness through the quadriceps muscle, um, of not enough hip rotation, not enough ankle mobility. There's so many different causes that can contribute to patellofemoral pain syndrome. But what happens is the forces around the patella start either pushing the patella into the groove or pulling it laterally. And because of that, it can lead to some anterior and or lateral knee pain. The biggest thing I want you to see is the patella, as it sits in the groove here, it's surrounded by soft tissue and musculature. And if there's not a balancing of forces anteriorly, above and below the knee, or medial and laterally, then the patella is going to take on increased force and increased pressure. And if you're overtraining or undertraining, let's say you just recently picked up running, because it's pretty common in running or downhill deceleration type of movements, then the patella, as it sits in the groove, can take on too much strain. And that's often because of the mechanical pull around the patella in various different directions. So the patella sits here. We have our rectus femoris, our quadriceps tendon. As it goes across the knee, it becomes the patellar tendon or patellar ligament. And the pull across there can really lead to increased pressure or increased force in the knee. So I'm going to stop sharing here and go back to the other diagram we had. We talked about other pathology, which could be the hip referring to the knee, lumbar radiculopathy, nerve pathology being the peroneal nerve injury. And then we just talked about some skeletal pathology, things that can relate. And that's going to be a fibular head fracture or patellar subluxation on the traumatic side, osteoarthritis on a degenerative changes in the knee, and then patellofemoral pain as abnormal tracking patterns around the knee. What I would say is osteoarthritis, patellofemoral pain syndrome, and then these soft tissue things that we're going to cover in the remaining of the video. Those are the bulk of what we see with musculoskeletal practice. And with that, it's the question always is, especially if it's a meniscal tear or some type of soft tissue, when do we bring other physicians on board? When do we bring other people on board to start helping with this problem? Or can it be managed with conservative treatment? So as we go over each one of these, we're going to talk about it from a mechanical input sort of side, but I want you to think about the degree of injury can often relate to whether or not we need to bring more hands on board. But as we talk about the soft tissue pathology, just know that all of these things can cause lateral knee pain, but the underlying cause or the underlying thing that we might need to address is going to be what's happening above and below at the hip or at the ankle. All right, so soft tissue pathologies. IT band syndrome, I almost drew a line connecting IT band syndrome with patellofemoral pain syndrome because those two, they both happen in an athletic population. They both can happen because of rotational movements or not enough stability around the hip joint. And they both sort of create a lateral pulling of the patella. So with that one, I'm going to go back over. We're going to talk about IT band, lateral meniscus, LCL injury, bursitis, different tendinopathies, and then synovitis or plica syndrome. And we're just going to pick away at these one at a time. So as we get back to the Essential Anatomy app, we're going to hide all the musculature to start. The first one I want to talk about is the plica or synovial fluid synovitis that can happen around the joint capsule. Now, plica are congenital folds in the knee that can lead to repetitive friction or they can lead to increased inflammation in the knee. I personally don't know whenever to refer if it's plica versus bursa versus some other benign thing in the knee. For me, all of those have a mechanical input. That means those structures are taking on too much strain that's leading to an inflammation or an aggravation of the knee. So no matter which one of those it is, we're going to treat it in a very similar fashion of unload initially so we can calm down symptoms and then gradually build up their ability to tolerate stress across the knee. But we're going to get into them anyways. So on the with that you can't really show the plica on the anatomy because there's they're just these added synovial folds. But this is the articular capsule or the joint capsule of the knee. And if there's too much redundancy or extra tissue here from some congenital thing, then that can lead to irritation of the knee or maybe some space occupying thing in the knee. But what I wanted you to see is how the breadth of how big the joint capsule is in supporting the knee. And that joint capsule helps maintain a synovial fluid balance in the knee, and that helps for a smooth, frictionless ability to flex and extend. So this is the joint capsule, which can often be related to plica type of injuries. Next, we have the LCL or fibular collateral ligament in the knee. And this one provides lateral stability. So you can think if you're doing your MCL and LCL testing, to test the LCL, you put one hand above the knee joint on the inside, you put your lower hand below the knee, and then you're trying to stress that ligament by gapping it, by putting an opening sensation through it. And by doing it in various positions, you'll see where the ligament is helping restrain movement versus if there was an injury to the knee, which that injury is going to be usually from a medial directed force. The only time I've ever seen this, I was working with a black belt in jujitsu, and her leg got basically traction and opened up from the inside of the knee. Most athletic injuries happen to the ACL and MCL because of a lateral directed blow to the knee where it opens up the inside. And that's just because the lateral side of the knee is more prone to taking on stress. Very rarely does someone get clipped on the inside of one of their legs, and that aggravates or traumatizes the LCL. So you can see that it runs from the femoral condyle down to the fibular head, and it's from a medial directed blow to the knee where we see that problem. So we talked about the joint capsule plica. We talked about the fibular collateral ligament. Next, I wanted to show you a few of the bursa in the knee. So here we have prepatellar bursa, a deep IT band bursa, and the bursa all over the body, they act as joint spacers, and they act as things that can allow for proper mechanical advantage over the knee. And if there's too much tightness around these, or they're taking on the soft tissues taking on too much stress and strain, then that's where we can see the bursa getting inflamed or aggravated. So we have our prepatellar bursa. There's one down here too, behind the patellar ligament, if we can show it. There's going to be one right back here, the inferior subtendinous bursa. And then lastly, we have our gastrocnemius lateral head. There's one on the medial side too. But as those bursa take on too much stress and strain, that friction across there can lead to an inflammation of them, and then that can lead to increased nociception, which can ultimately lead to some pain. As I said earlier, the strategy for all of these is we need to unload the painful tissue and then gradually build up our body's ability to tolerate that stuff. So I'm going to go back to our mind map real quick. We talked about IT, well, actually, not even fully IT band syndrome, LCL ligament. We talked about bursitis. We talked about the plica syndrome. Next, we're going to get into some of we're going to talk about the lateral meniscal tear, and then we're going to go over IT band and tendinopathy. To get into the lateral meniscus, just from a layering standpoint, I want you to see that we have to first, we're going to hide the articular capsule of the knee. We're going to hide the synovial membrane. So I would think about those articular capsule and the synovial membrane as added layers of redundancy to allow for proper stability around the knee joint. As we hide both of those, we can start seeing inside the knee joint here. So where the meniscus is going to be that's the articular condyle. We're going to go right above that, and that's going to be our lateral meniscus. As I isolate the lateral meniscus, you can see that it's this big O-shaped structure that covers the whole lateral side of the knee, and it is significant for helping with shock absorption. Now, the meniscus overall does really well with compressive loading. If it takes on some undue twisting or shear type of movements is where we might see some injury to the meniscus. Based on its fiber structure, it does not respond as well to twisting and loading sort of movements. With that being said, if you have good strength at your hips and good adaptability, reactive time of your nervous system, it can handle a ton of rotational stress. But at a certain point, if the whole system isn't ready for it, where it will feel compromised is with lateral twisting, pivoting, and loading type of movements. But the lateral meniscus can be a source of lateral knee pain. I wanted you to see how it's deep to the synovial fluid layer. It's a structure that's deep to the LCL ligament. It's very much embedded into the knee, and it sits right on top of the articular condyle of the tibia. So it sits right on that articular cartilage surface of the knee. So we talked about most of the soft tissue things that can cause lateral knee pain. Now we're going to add some muscular layers on and talk about IT band syndrome and distal popliteus and biceps femoris tendinopathy. Okay, with the IT band syndrome and iliotibial tract syndrome and patellofemoral pain syndrome can often present similarly. And what I would say is clinically, I'm going to be looking for the impairments that are happening around the knee, the weakness at the hip, the instability or not enough strength around the ankle. Those are the things that can contribute to what happens above and below. With the IT band, it's the function, if you look at the connection of the IT band from its insertion to its origin to its insertion, the IT band starts as the TFL, the tensor fascia lata. So the the tensor fascia lata, its function is to tense the fascia lata structure of the lateral knee. So you have your TFL, which is a hip abductor, it's a hip flexor, and it's a hip internal rotator. If the TFL is tight or it's getting overworked, or the core musculature right above it isn't supporting the TFL, then we're going to see some relative dominance or overactivation of the TFL, which has a direct mechanical pull to its distal insertion, which is the IT band. So the IT band runs from the TFL across the knee joint onto the lateral tibial condyle. It also has insertion points onto the lateral patellar retinaculum. And so earlier we talked about patellofemoral pain issues. And so if the IT band, which attaches onto the lateral patellar retinaculum, is getting pulled on, it will mechanically pull the patella in a lateral position. From a significant standpoint, the IT band tracks right over the lateral femoral condyle. So some people say that it has attachment onto the lateral femoral condyle. Either way, we know that based on the angle of pull and the insertion, it can create a lot of irritation right at that distal lateral femoral condyle area. So it's because of how the IT band attaches there, where it's going to create friction or where it's going to create pull is on the lateral side of the knee. But the biggest kind of most important thing I want you to think about is if someone comes in and when they go down into a squat position or if they're single leg stability, if they're really dropping into internal rotation, that pulls from the TFL down across that structure in the knee. And that is significant for creating increased friction around the knee joint. As we go from anterolateral to posterior lateral, we can see our hamstring muscles. So on the medial side of it, we have our semitendinosus and semimembranosus. Those are two of the big hamstring tendons. Next, we go laterally, which is our biceps femoris. We have our long head of the biceps femoris, where if we isolate that, you can see how the long head runs along down to the fibular head. So long head of the biceps femoris tendon. And then if we go laterally again, here's the long head that we were just on. If we go just anterior to that, we have our short head of the biceps femoris tendon. And both of those come together pretty much near a common origin along the fibular head. So we're going to isolate the short head real quick, and you can see that. It's going to be just anterior to where the long head attaches on the fibular head. Now, the hamstring muscles as a unit, they can help control eccentric forces as you're running or walking. So the way that someone would get some sort of distal hamstring tendonitis is if they significantly increase their activity level, or if they started running or picked up a new sport or started training at a increased pace. That's where we're going to see a tendinopathy occur. And tendinopathies always occur because the rate at which something is being stressed versus the rate at which that tissue can heal is there's an imbalance between that. So if someone's working their hamstrings, and that's where your mechanism of injury or the person's history is going to be really important. If they come in and they say, oh yeah, I recently picked up running again, well, that's a lot of new force controlling around the knee that we have to think about. And so most likely the attachment point of where the hamstring muscle belly turns into its tendinous attachment, either on the short or the long head, that can create irritation or an overuse of that tendon. So most likely we need to work on some hip strategy. We need to strengthen the hamstring muscles, but not in such a load intensive format. But things like that is when someone will come in with that lateral knee pain location. that then hurts when you can reproduce it when you're doing different hamstring driven movements. The last one we're going to talk about, which clinically I think is hard to decipher, but I just want to show you the muscle from origin to insertion, is going to be, let me hide these. And I'm going to show you the popliteus muscle. Now the popliteus, we cannot really voluntarily train or work this muscle, but it's one of the sources that can happen from with lateral knee pain because of where it runs. So you see how if we isolate this muscle, it runs from the lateral condyle of the femur. So there's the lateral condyle. So if it's getting pulled on excessively, and then it runs down onto the backside, the posterior surface of the tibia. This muscle is very important for locking and unlocking of the knee. Now, as I said a minute ago, we can't really train this muscle per se, but we can make sure that someone is getting into full extension, where as you go into full extension, the lower leg needs to externally rotate, and then as you bend your knee, then it has a reciprocal internal rotation of it. And by watching someone's different movement patterns, watching how they squat, watching how they lunge and go into knee flexion and extension, we can help out with any popliteus tendonitis or tendinopathy by making sure that their knee is locking and unlocking appropriately. What I would look for if someone's doing a squat and they stay very laterally on their foot, meaning they're stuck in supination of the foot, supination is not going to allow for that proper excessive supination is not going to allow for proper knee flexion, and then they're likely not getting proper internal rotation of the knee. So looking at the mechanics of how the knee moves is going to direct you into whether or not the popliteus can be taking on too much stress and strain. I would, with this, you can do some different mobilizations to the lower knee joint to make sure that that the knee can move into internal and external rotation. And then we can also do things like single leg balance, where we're making sure that the knee isn't getting pulled too much into dropping into an internal rotation valgus position. But what I would say is if you focus on proper mechanics around the knee, then we're likely going to see we can calm down what's happening with the popliteus muscle or overuse of the popliteus. I would also say, think about this in relation to what we just talked about with the distal biceps tendonitis or tendinopathy, where if that's taking on too much stress and strain, it's likely causing local irritation to the popliteus tendon. So there's going to be some overlap between those two. That is an overview of the differential diagnosis of lateral knee pain. Again, we have the other pathology things that can contribute to it, potential nerve pathology, skeletal pathology, being anything that happens to the skeletal structure, the patella, the fibular head, the joint condyles itself, or the kneecap. And then lastly, our soft tissue pathology for lateral knee pain is going to be the IT band, the lateral meniscus, an LCL injury, bursitis, tendinopathy, or it could be our synovitis/plica syndrome. So those are all the potential things that can happen to the lateral side of the knee. Again, if you like this video, if you want to see more of this type of stuff, please like it, subscribe, add comments below on where I can delve deeper on different things. I'm here to help make this a better learning experience. So chime in on how we can achieve that. So have a good day. Thank you so much.